So now we'll be talking about the musculoskeleton, that is the supraspinatus, rotator cuff muscle supraspinatus by suprascapular nerve, abducts arm initially before the action of deltoid, most commonly rotator cuff trauma or degenerate and impingement, tendinopathy or tear, assessed by the empty can test. Infraspinatus, we have suprascapular nerve, external rotation arm, reaching injury, teres minor axillary nerve, eviduct, adduct, and externally rotate. So infraspinatus and teres minor both extra does is the external rotation. We have subscapularis, which does internal rotation, and subscapularis is supplied by upper and lower subscapular nerve and abducts the arm, innervated primarily by C5 and C6. So we have the arm abduction 0 to 15 degree. We have supraspinatus, 15 to 90 degree deltoid, greater than 90 degree trapezius, and greater than 90 degrees serratus anterior. So the serratus anterior is supplied by long thoracic nerve, trapezius supplied by accessory nerve, deltoid supplied by axillary nerve, and supraspinatus supplied by suprascapular nerve. So upper extremity nerve injuries are axillary C5 to C6, where we have the fractured surgical neck of humerus and anterior dislocation of humerus. Presentation is the flat deltoid, loss of arm abduction and at shoulder greater than 50 degree, loss of sensation over deltoid and lateral arm. So next we have the musculocutaneous C5 to C7, upper trunk compression, decreased bicep reflex, loss of forearm flexion and supination, loss of sensation over radial and dorsal forearm. Next we have the radial nerve injury, that is C5 to T1, compression of axilla due to crutches or sleeping with over armchairs, Saturday night palsy, which have fracture of humerus, related pronation and supination of forearm due to screwdriver use. Injuries of radial nerve injuries above the elbow causes loss of sensation over the posterior arm and forearm and dorsal hand. Wrist drop, lot of elbow wrist and sorry. Okay, so wrist drop, loss of the elbow wrist and finger extension, decreased grip strength, wrist extension necessary for maximal action of flexors. Injury below the elbow causes distal paresthesia without wrist drop. So tricep functions and posterior arm sensation is spared in medial shaft fracture. So next we have median nerve C5 to T1, supracondylar fracture of humerus injury, proximal lesion of nerve, carpal syndrome, wrist laceration and distal lesion of the nerve. So in median nerve we have epihand and the hand of the Benedict, loss of wrist flexion and function of the lateral two lumbricals, opponent's pollicis, abductor pollicis brevis and flexor pollicis brevis, loaf is the mnemonic, loss of sensation over the thenar eminence and dorsal and palmar aspect of the lateral 3.5 of finger with proximal lesion. Ulnar nerve is C8 to T1, that is fracture of medial epicondyle of humerus, funny bone, proximal lesion, fracture hook of hamate, distal lesion from fallen outstretched hand. Presentation of ulnar nerve is ulnar claw and digital extension, radial deviation of the wrist upon flexion, proximal lesion, decreased flexion of the ulnar nerve, abduction and adduction of finger, introasign, thumb adduction, action of the ulnar two lumbricals muscles, loss of sensation over the ulnar 1.5 finger including hypothenar eminence, where recurrent branch of median nerve, that is C5 to T1, superficial lateral of palm, epihand, loss of the thenar muscle group opponents, abduction and flexor of thumb, loss of sensation. So humerus fracture proximity to distally follows the RF, axillary, median and median nerve. So when we talk about the hand, radial nerve supplies we have the ulnar nerve on the dorsal surface, okay, and radial nerve supplies the just above the 3.5 fingers, okay. So thumb is supplied by radial, but the median nerve is supplied on the dorsal aspect by only to the fingers only, 3.5 fingers, whereas distal to the fingers is supplied by radial nerve. Similarly, median nerve is supplied by 3.5 in the palmar aspect, and the rest is by ulnar nerve, and little bit side on the thumb area by radial nerve. So we have the reflexes, that is when you talk about the CFAB, the bicep reflex. So next we have the median nerve, that is C5 to T1. Okay, we have the supracondylar fracture of humerus, proximal lesion of the nerve, carpal syndrome, wrist laceration and distal lesion of the nerve. So epihand, hand of the Benedict, we have the loss of sensation over the thenar eminence, dorsal and palmar aspect of lateral 3.5 finger with proximal lesion. Next we have the ulnar C8 to T1, that is fracture of medial epicondyle of humerus, funny bone, proximal lesion and fractured hook of hamate, distal lesion from fallen outstretched hand. We have the ulnar claw and digital extension, radial deviation of wrist upon flexion, proximal lesion, decreased flexion of ulnar nerve, abduction and adduction of finger of introasign, thumb adduction and action of ulnar two lumbrical muscles, loss of sensation over the ulnar 1.5 finger including hypothenar eminence, We have recurrent branch of median nerve, superficial C5 to T1, superficial laceration of the palm, epihand, loss of thenar muscle group, opponents, abduction and flexor of thumb, no loss of sensation. Okay, so next we have the C5 does the bicep reflex, C6 does the bicep and brachiobrachiosaurus reflex, C7 does the tricep, okay, and C8 does the finger flexion, and T1 does the finger flexion. Okay, so next we have sensory innervation. C5 does the lateral upper arm, C6 does the thumb index finger, C7 does the dorsal forearm middle finger, C8 does the ring little finger, and T1 does the middle finger. Similarly, the C5 weakness leads to shoulder abduction, deltoid, and elbow flexion bicep. C6 does weakness of the elbow flexion, forearm pronation and supination, and wrist extension. C7 does elbow extension weakness and wrist flexion. Similarly, C8 does the weakness on the finger flexion and extension and thumb flexion and abduction, whereas T1 does the weakness of finger abduction and adduction. Similarly, in the brachial plexus, we have a mnemonic of MARMO, M-A-R, that is musculocutaneous, A for axillary, M for median, and M-A-M, MAM, MAR, M-A-M-R-U. Okay, so musculocutaneous, axillary, median, radial, and ulnar. Okay, so from the root arises the long thoracic nerve. From C5 to T1 is the brachial plexus. We have upper, middle, and lower trunk. So that both divide into anterior and posterior divisions. Then we have the cord, that is lateral cord, posterior cord, and the medial cord. Okay. So from the posterior cord arises the axillary nerve and the radial nerve. From the lateral cord arises the musculocutaneous nerve and the median nerve. Okay. And from the lateral and medial arises the median nerve. Okay. And from the median cord arises the median nerve and the ulnar nerve. Okay, so division of the brachial plexus is RT, root, trunk, division, cord, and branches. So next we have the ear palsy. Inbuilt palsy, also known as the waiter's tip, is a traction or tear of the upper trunk C5 to C6, infants lateral traction on the neck during delivery, adult trauma. We have the muscle deficit as deltoid, supraspinatus, infraspinatus. Okay, adult deltoid deficit and supraspinatus deficit does abduction, arm hang by side, infraspinatus and supraspinatus does lateral rotation, arm medially rotated, bicep brachii does flexion, supination, and arm extension and pronated. Similarly, we have clump palsy, that is traction of the tear of the lower trunk C8 to T1, infants upward force on arm during delivery, and adults trauma, grappling or tree branch break on fall. Next we have the muscle deficit during intrinsic muscles, lumbricals, introirsal, and thenar. So there is claw hand, lumbricals normally flex MCP joint and extends DIP and PIP joint. The thoracic outlet syndrome, that is compression of the lower trunk and subclavian vessels, most commonly within the scalene triangles, caused as clavicle rib, that is varicose tumor, and same as clump palsy, atrophy of intrinsic muscles hand, ischemia, pain, edema due to vascular compromise. Next is winged scapula, that is lesion of the long thoracic root C5 to C7. So the cause is axillary node dissection after mastectomy or stab wounds. One is serratus anterior, so immediately to anchor scapula to thoracic case, cannot abduction, arm above horizontal direction. Next we have the wrist, that is scaphoid, lunate, triquetrum, and pisiform. So when you look at from the thumb to little finger, we have the scaphoid, lunate, triquetrum, and pisiform. Similarly, just above the scaphoid, we have the trapezium, and that is the first MCP joint. Then the beside that there is trapezoid, then capitate, and hamate. Okay, so now scapula palpebral anatomy work is the most common fractured carpet bone, typically due to fallen outstretched hand. Complication of proximal scaphoid fracture includes avascular necrosis and non-union due to retrograde flow of the branch of the radial artery. Occult fracture not always seen on initial X-ray. Dislocation of lumen may impinge the medial nerve and cause carpal tunnel syndrome. So inside these six common flexor digitorum profundus tendon are 4. Okay, and we have flexor pollicis longus tendon 1, and we have flexor digitorum superficialis tendon 1, and the median nerve. Okay, so the next is hand muscles, thenar, and the thenar median, there is opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis, and superficial head, that is deep head of ulnar nerve. So hypothenar is ulnus, there is opponens digiti minimi, abductor digiti minimi, and flexor digiti minimi. So dorsal introici epiducts the finger, that is dorsal dab and pad. So dab, dorsal epiduct, and palmar adducts. Okay, so lumbricals first and second by medianum and third fourth by ulnar nerve. Flex at the lumbricals, flex at the MCP joint and extends at PIP and DIP joints. Okay, so distortion of the hand. So at rest, the balance exists between the extrinsic flexors and extensors of the hand, as well as the intrinsic muscles of the hand, particularly the lumbricals muscles. The lumbrical flexor of the MCP and extension of the DIP and PIP joint, clawing, best seen with the distal region of the median and ulnar nerve. Remaining extrinsic flexors of the DGJ exaggerate the loss of the lumbricals. Finger extended at MCP, flex at PIP and DIP joints. Deficit less pronounced in proximal lesion. Deficit presents usually voluntary flexors of the digit. So we have the claw hand, that is the extending finger at rest, and content location at lesion as distal ulnar nerve. So we have the hand of benediction, that is making a fist. So proximal medial nerve. So we have the next is median claw, that is extension. So at rest, balance exists between the extensor flexors and extensor of the hand, as well as the intrinsic muscles of the hand, particularly the lumbricals, flexor of MCP and extension of DIP and PIP, clawing best seen with the distal lesion of the median and ulnar nerve. Remaining extrinsic flexors of digit exaggerate the loss of the lumbricals. Fine extends at MCP and flex at DIP and PIP joints. Deficit less pronounced in proximal lesion. Deficit presents usually voluntary flexors of the digit. So ulnar claw is with the distal ulnar nerve, whereas the median claw is with the distal median nerve. Okay. So hand of benediction is making a fist. While making a fist, there is proximal median nerve injury. Okay. And Okegester is making a fist prominent with the ulnar nerve. So atrophy of thinner remains can be seen in median nerve injury, while the atrophy of hypotension can be seen in ulnar nerve injury. So we have the action of the hip muscles, that is the abductors, that is gluteus medius and minimus. Adduction is done by adductor magnus, adductor longus, adductor brevis. Extension is done by gluteus maximus, semitendinous, semimembranous. Flexors are iliopsoas, rectus femoris, tensor fasciae lata, pectineus, and sartorius. Internal rotation is done by gluteus medius, gluteus minimus, and tensor fasciae lata, whereas the external rotation is done by GOP, that is G for gluteus maximus, O for obturator, and P for piriformis, and I for iliopsoas. So next is lower extremity nerves. So we have the iliohypogastric, that is T12 to L1, that is sensory suprapubic region, motor transversus abdominis, and internal oblique. Cause of injury is the abdominal surgery. Okay, and the presentation is burning or tingling pain in the surgical incision site relating to inguinal and suprapubic region. Next we have genitofemoral, that is L1 to L2. Sensory scrotum, labia majora, medial thigh. Motor is cremastic. Cause of injury laparoscopic surgery. Presentation with decreased medial thigh and anterior thigh sensation beneath the inguinal ligament, lateral part of the femoral triangle, and absent cremastic reflex. Next we have the lateral femoral cutaneous nerve, that does sensory anterior and lateral thigh, tight clothing, obesity and pregnancy, and pelvic procedure, decreased sensation and decreased thigh sensation. We have obturator nerve, that is L2 to L4, sensation, sensory medial thigh, motor obturator externus, adductor longus, adductor brevis, gracilis, and pectineus, and adductor magnus. We have pelvic surgery, cause of injury, presentation with decreased thigh presentation, medial and adduction. So next we have the so now we'll be talking about the obturator nerve, that is L2 to L4. Okay, so sensory medial thigh, motor obturator externus, adductor longus, adductor brevis, gracilis, pectineus, and adductor magnus. Pelvic surgery, decreased sensation on the medial and adduction. Femoral L2 to L4, sensory anterior thigh and medial thigh, motor is quadriceps, iliacus, pectineus, and sartorius. Cause of injury is pelvic fracture, and presentation is decreased leg extension and decreased patellar reflex. So in the sciatic we have L4 to S3. So motor is semitendinous, semimembranous, biceps femoris, and adductor magnus. So cause of injury is herniated disc, posterior hip dislocation, split into common peroneal and tibial nerve. So next we have the common fibular peroneal, that is L4 to S2. So we have the superficial peroneal nerve, sensory dorsum of the foot and axial wave space between the helix and the second digit. Motor is peroneus, longus, and brevis. Next we have the deep peroneal nerve, which is sensory wave space between the helix and second digit. Motor is tibialis anterior. So cause of injury is trauma or compression of the lateral aspect of leg, fibula, neck fracture. So presentation is Fairness inverts and dorsiflex. If injured, foot drops. Okay, so loss of sensation on the dorsum of the foot inverted and plantar flexed at rest, loss of eversion and dorsiflexion, steepest gait. Okay, foot drop is inverted and plantar flexed, at rest, so loss of eversion and dorsiflexion. So lower extremity tibia is L4 to S3, so sensory is on the sole of the foot, and the motor is bicep femoris, long head, triceps surae, plantaris, and popliteus, and plexus of foot. So trauma is knee trauma, Baker's cyst, proximal lesion, tarsal tunnel syndrome, and distal lesion. So presentation of tibial nerve is steep. So tibia inverts and plantar flex. If injured, cannot stand on a tiptoe. Okay, tiptoe मा गर्न सकिने भनेपछि हाम्रो tibial nerve गयो भन्ने भन्नु. Inability to curl toes and loss of the sensation of the sole. If proximal lesion, foot everted at rest, while weakened inversion and plantar flexion. So next we have the superior gluteal, that is from L4 to S1. So innervation is motor gluteus medius, gluteus minimus, and tensor fasciae lata. Cause of injury is iatrogenic injury during intramuscular injection on superior gluteal medial region, pivoted by choosing superlateral quadrant, preferably anterolateral region. So superior gluteal nerve, there is Trendelenburg sign and gait. Curved tails, because of the weight-bearing leg cannot maintain alignment of the pelvis through hip abduction. So lesion in the contralateral to side of the hip that drops ipsilateral to external on which the patient stands. Next we have the inferior gluteal, that is L5 to S2, motor gluteus maximus, posterior hip dislocation, difficult climbing stairs, rising from seated position, and loss of hip extension. So next we have the pudendal nerve, that is S2 to S4. So innervation is sensory, perineum, motor external urethral and anal sphincter. Pudendal nerve suffered stress injury during the childhood and prolonged cycling, horseback riding. So presentation of the pudendal nerve injury is decreased sensation in perineum and genital area, can cause fecal and urinary incontinence, can be blocked with local anesthesia during childhood using ischial spine as a landmark for injection. So similarly, the L4, L2 to L4, reflux patellar, sensation one is enter medial thigh and medial sign, weakness is hip flexor and hip abduction. Okay, plus knee extension is also impaired in the quadricep and the iliac hip flexor, that is gone. L5, no reflex is gone, lateral shin and dorsal of the foot, and weakness in the foot dorsiflexion, foot eversion, and foot extension. Okay, L5 gone means foot dorsiflexion is gone, inversion is gone from tibialis anterior, foot eversion from peroneus and to extension, and extensor hallucis digitorum is gone. So S1 arc disc reflux is gone, and post sensation is posterior calf sole and lateral foot, and the weakness is hip extension, gluteus maximus, and foot plantar flexion, that is gastrocnemius. Next we have the S2 to S4, that is the on the perineum region, urinary fecal incontinence and sexual function is gone. So on the knee examination, lateral femoral condyles to anterior tibia and medial condylar condyle to posterior tibia. Okay, anterior draw test is we know about the anterior draw test, that is bending knee at 90 degree, increase anterior gliding of the tibia relative to femur due to ACL injury. Lachman test also tests ACL, but is more sensitive. It is anterior gliding of tibia relative to femur with the knee bent at 30 degree. So initial bending was anterior draw test is at 90 degree, whereas the Lachman test is at 30 degree. So posterior draw test is bending knee at 90 degree, increased posterior gliding of the tibia due to PCL injury. So posterior draw sign is bending knee at 90 degree, increased posterior gliding of tibia due to PCL injury. So posterior draw test is 90 degree, anterior draw test is also at 90 degree. So abnormal passive abduction is lateral valgus test, knee extends at 30 degree, lateral valgus force, medial spaced widening of the tibia, MCL injury. So we have the abnormal passive adduction, that is the varus test, knee either extended or at 30 degree angle, medial varus force, lateral space widening of tibia, LCL injury. McBoy's test, during flexion extension of the knee with rotation of the tibia and foot, Lyme is the mnemonic. So pain popping on the internal rotation and varus force is lateral medial steer, internal rotators, stressors, and external lateral meniscus, whereas pain popping on external rotators and valgus force is medial meniscus steer, and external rotation, stress, and medial meniscus. So we have the ankle sprain, that is anterior talofibular ligament, most common ankle sprain overall, classified as the lower ankle sprain due to lower over inversion and supination of the foot, always chair first. You have the anteroinferior tibiofibular ligament, most common high ankle sprain. Okay. Next we have the sign of lumbosacral radiculopathy, paresthesia and weakness related to specific lumbosacral spinal nerve, intervertebral disc, nucleus pulposus or net posterolaterally through annulus fibrosis into a central ring due to the thin posterior longitudinal ligament and thicker anterior longitudinal ligament along midline of vertebral bodies. Now affected is usually below the level of herniation. So L3, L4 bone. Now root affected is L4, and weakness of the knee extension and decreased particular reflex. Whereas when you talk about L4, L5, the L5 is gone, so weakness of dorsiflexion and difficulty in healing walking. When L5 and S1 is gone, S1 is gone, so weakness of plantar flexion, difficulty in toe walking, and decreased arteries. Okay, so neurovascular pairing, we have the axillary lateral thoracic, long thoracic, lateral thoracic, surgical neck of humerus location, knob injury, surgical neck of humerus, axillary, posterior circumflex artery, mid-shaft of humerus, radial knob, deep brachial artery, distal humerus and cubital fossa, we have medial knob in brachial artery, posterior fossa we have tibial knob and popliteal artery, posterior to medial malleus is tibial knob and posterior tibial artery. So now we'll be talking about the motor action of potentials. So now we'll be talking about the physiology of the MSK. So the tubules are extension of plasma membrane in contact with the sarcoplasmic reticulum, allowing for coordinated contraction of the striated muscles. So action potential opens presynaptic bonnet voltage-gated calcium channel, including acetylcholine release. Postsynaptic ACS binds lead to muscle cell depolarization at the motor end plate. Depolarization travels over the entire muscles and deep into the muscles by tubules. Muscular depolarization induces conformational change in the voltage sensitive dihydropyridine receptor and is mechanically coupled ryanodine receptor. Calcium released from the sarcoplasmic reticulum into the cytoplasm. Then the tropomyosin is blocking myosin and binding site on the actin filaments. Released calcium binding to troponin C, shifting tropomyosin to exposure, the myosin binding site. The myosin head binds strongly to the actin, forming a cross bridge. PI is then released, initiating the power stroke. During the power stroke, force is produced as the myosin pulls on the thin filament. Muscle shortening occurs, while shortening of H and I bands and between Z lines. So SIZ shrinkage. Okay, and the A band remains the same length. The A band is always the same length. ATP is released at the end of power stroke. Binding of new ATP causes detachment of myosin head from actin filament. Calcium is sequestered. ATP hydrolysis into ADP and PI phosphate in myosin head, returning to the high position, that is cogged. The myosin head unbinds to a new site on the actin to form a cross bridge if calcium remains available. The uptake of the calcium or sarcoplasmic reticulum, calcium metabolism, sarca, muscle relaxation. So now we have the type of skeletal muscles, that is type 1 and type 2. Type 1 muscles are slow, rate, oxidative phosphorylation, sustained contraction, and increased mitochondria, increased myoglobin. Type of retaining is endurance training, and thinking slow redox. So type 2 is the fast, wide, anaerobic glycolysis, weight training, resistance training, sprinting. Okay, so muscle scaling adaptation is like atrophy, there is decrease in removal by ubiquitin protease system, and myofibrils are decreased in atrophy, and myonuclei are also decreased in atrophy. So in hypertrophy, there is addition of the sarcomere in parallel and increased fusion of satellite cells. In hypertrophy, there is increased fusion of the satellite cells. Okay, when you talk about the endothelium, the acetylcholine and bradykinin and acts as an agonist on the receptor. Then the endothelium, it is acting on the SCH and bradykinin acts as an agonist into the endothelium receptor, release the calcium. Calcium induces the NO synthase from L-arginine to form the NO. NO diffuses into the smooth muscle cells of the endothelium, and NO activates from GTP to CGMP, and CGMP potentiates the action of myosin light chain kinase phosphatase, okay, and doing the relaxation. When for the contraction, we have altered voltage-gated calcium channel in the smooth muscles, so that increases the calcium carbon complex and binds with the myosin light chain kinase. So that myosin phosphate acts, and there is a contraction. So increased calcium does contraction, nitric oxide does relaxation in the vascular skeletal muscles. Okay, and there is the muscle proprioception, special sensory receptor that relay information about the muscle dynamics. We have muscle stretch receptors, increase length and speed of the stretch by dorsal root ganglia, activation of inhibitory neurons, alpha motor neurons, stimulation inhibition of antagonist muscle prevents overstretching and activation of the agonist muscle contraction. So location and inversion is the body of the muscle, type 1A and 2 sensory axons, and muscle stretch receptor increase the muscle stretch responsible for deep tendon reflexes. We have Golgi tendon organ, increased tension by DRG, dorsal root ganglia, activation in inhibitory neurons, inhibition of the agonist muscle, reduction tension in the muscles and tendon. We have Golgi tendon organ called the tensor type B, 1B sensory axons, and increased muscle tension. Okay. So, bone formation, there is endocondylar ossification, bone of the axial skeleton, appendicular skeleton, and the base of the skull. Cartilage model of bone is first made by chondrocytes. Osteoclast and osteoblast later replaced with the oven bone, and remodeling to the lamellar bone. In adult, oven bone occurs after fracture and in Paget's disease, defective in achondroplasia. Next, we have the membranous ossification, which is the bone of the calvarium, waist bones, clavicles. Oven bone formed directly without cartilage, later remodeled to lamellar bone. Now we have the cell biology of the bone, that is osteoblast. It builds bone by secreting collagen and catalyzed mineralization in alkaline environment by ALP. Differentiate from mesenchymal stem cells in periosteum. Osteoblastic activity measured by bone, ALP, osteocalcin propeptide of type 1 procollagen. Next we have the osteoclast that dissolves crosses bone by secreting H plus and collagenase. Differentiate from a fusion of monocyte macrophage lineage precursor rank receptor on osteoclast are stimulated by rank ligand expressed on osteoblast. OPG, osteoprotectin or rankle decoy receptor binds rankel to prevent the rankle interaction and decrease osteoclastic activity. Next we have parathyroid hormone at low intermediate level exerts anabolic effect, build bone on osteoblast and osteoclast indirectly. Chronically increased PTH in hyperparathyroidism cause catabolic effect or status fibrosis cystica. Next we have the osteoestrogen, which inhibits the apoptosis in a bone forming osteoblast and induce apoptosis in bone resorbing osteoclast, cause closure of avivisal plate during puberty. Estrogen deficiency, surgical or postmenopausal, increased cycling of remodeling and bone resorption, increased risk of osteoporosis. Okay, so next is overuse or injury of. So we will now start the pathology. So overuse injuries of the elbow, that medial epicondylitis or Goffler's elbow, repeated flexion or idiopathic pain near the medial epicondyle, lateral epicondylitis, which is also tennis elbow, repeated extension and backhand shot or idiopathic pain near the lateral epicondyle. So radial knob, wrist extension. Clavicle fracture common in the child as after birth trauma, usually caused by a fallen nose to his head or by direct trauma to shoulder, which by the injury of the middle and the lateral third fracture at the middle segment are most common. Present at the shoulder drop or shortened clavicle, lateral fragment is displaced due to the arm weight and medially rotated by the arm adductors like the pectoralis major. Wrist and hand injuries is done by Guinan canal syndrome. Compression of the ulnar knob at wrist, classically seen in cyclists due to the pressure from hand players. Carpal tunnel syndrome, we have the entrapment of the median nerve in the carpal tunnel between the transverse carpal ligament and carpal bones. Knob compressions, paresthesia, pain, numbness in distribution of median nerve, thinner eminence atrophies, but the sensation is spared because of the palmar cutaneous branch enters the hand extensor to the carpal bone. So carpal tunnel syndrome is such a tunnel sign. Percussion of the wrist cause tingling and penile maneuver, 90-degree flexion of the wrist cause tingling. So associated with the pregnancy due to edema, rheumatic arthritis, hypothyroidism, diabetes, acromegaly, dialysis-related amyloidosis may be associated with the repeated use. Next, we have the metacarpal neck fracture, also called as boxer's fracture, common fracture caused by direct blow with a closed fist from punching a wall, most common seen in fifth metacarpal. So we have the unhappy triad, common injury in contact sports due to the lateral directed force to the plantar foot, consist of damage to the ACL, MCL, and medial meniscus attached to the MCL. However, the lateral meniscus is involved more common than the medial meniscus involved in connection with the ACL. MCL injury felt with the acute pain and sign of joint instability. Prepatellar bursitis, inflammation of the prepatellar bursa in front of the kneecap and caused by repeated trauma or pressure over the excessive knee, also known as house-made knee. Next we have the popliteal cyst, also known as the Baker's cyst. Popliteal fluid collection in gastrocnemius, semitendinous bursa commonly communicates with the synovial space and related to the chronic joint disease, osteoarthritis and rheumatic arthritis. Next common muscular tissue, due tendonitis, non-inflammatory thickening of abductor pollicis longa and external sulfuritis brevis tendon, pain at the tendons at the radiosteroid joint. Frankenstein test is positive, pain at the radiosteroid with the active or the passive stretch of the thumb tendons, increased risk with the lift waving, golfers, racket, sport players, and thumb textures. Okay, ganglion cyst, fluid-filled cyst overlying the joints or tendons, most commonly involved on the dorsal abscess. There is like this from herniation of the disc. Connective tissue evolves spontaneously. So iliotibial band syndrome, overuse injury to the lateral leg, knee, that occurs primarily in runners. Okay, So that is pain during the secondary friction of iliotibial band against the lateral femoral condyle. So next is limb compartment syndrome, increased pressure with the facial compartment of the limb, venous outflow obstruction, the anterior collapse, anorexia and necrosis. Cause include significant long bone fractures, reperfusion injuries, animal venoms present with the severe pain and tendon swollen compartment with the passive stretch of the muscles in the affected compartment, increased serum creatinine kinase and motor deficit early of irreversible muscles and nerve damage. We have pain, pallor, paresthesia, musclelessness and paralysis. Next we have the medial tibial stress syndrome, also known as shin splint, common cause of shin pain and diffuse tenderness in runners, military recruits, also caused by bone resorption, then outplaces the bone motion in tibial cortex. Next we have plantar fasciitis, inflammation of the plantar aponeurosis characterized by the heel pain, works with the first step in morning or after a period of inactivity and tenderness. Temporomandibular distorts. So a group of the disorders includes the temporomandibular and muscles of mastication, multifactorial as with the TMG, trauma, poor head and neck posture, abnormal trigeminal nerve pain processing, psychological factors, presence with dull constant unilateral facial pain that worsens with the jaw movement, otalgia, head, TMG dysfunction, limited range of motion. So now we have the childhood musculoskeletal conditions like radial head subluxation, also called nursemaid elbow, common elbow injuries in children less than 5 years caused by the sudden pull on the elbow, immature endor ligament slips over the head of the radial, injured arm head in slightly flexed and pronated position, and as good slaughtered disease, also known as the traction epiphysetes, overuse injury caused by repeated strain and chronic avulsion of the secondary ossification center of the proximal tibial tubercle, occurs in adolescent after growth spot, commonly in runners and jumping athletes, common with progressive anterior knee pain. Patellofemoral syndrome, ovaries injuries that commonly present with young female athletes as anterior knee pain, exhibited by prolonged sitting or weight bearing on a flexed knee. Developmental dysplasia is abnormal acetabulum development in newborn. Risk factor is breast presentation, result in hip instability and dislocation. Commonly tested with Otolani and Barlow maneuver. Manipulation of newborn hip reveals occur. Find with ultrasound. X-ray not used until 4 to 6 months because cartilage is not ossified. We have leg carpal disease, idiopathic or vascular necrosis of femoral head, commonly present between 5 to 7 years with serious onset of hip pain that may cause hip to heal. More common in males, 4 to 1 ratio. Initially, X-ray are often normal. So, sleep capital femoral epiphysis, classical present with the young adolescent hip knee pain, altered gait, increased axial force on the femoral head. Epiphysis displays related to femoral neck, like a scoop of ice, creaming, and a bone diagnosed with Wiley X-ray. Next, we have the green stick fractures, incomplete fracture extending partway through the width of the bone following the bending stress. Bone fails on the tension side, compression side intact. Bone is absent like a gritted. Now we have torus fracture, that is axial force applied on immature bone. Cortex buckle on the compression side and fracture. Tension convex and side remains solid. We have achondroplasia, failure of the longitudinal bone growth, endochondral ossification, short link, membranous ossification is not affected. Large heteroactively constitutive action of the fibroblast growth factor receptor FGFR3 actually inhibits chondrocyte proliferation. More than 80%, 85% of mutation occurs sporadically. Autosomal dominant with full penetration homozygosity is lethal, as with increased paternal age, most common cause of short limb dwarfism. Next, we have the osteoporosis, that is the trabecular, spongy, and cortical bone loses mass despite normal bone mineralization and lab values serum calcium and phosphate, most commonly due to the increased bone resorption related to decreased estrogen level and old age. Secondary can be secondary to drug like steroids, alcohol, anticonvulsants, anticoagulants, eye replacement therapy, or other conditions like hyperparathyroidism, multiple myeloma, malabsorption syndrome, and anorexia. Diagnosed by bone mineral density measured by DEXA, dual energy X-ray absorptiometry at the lumbar side, total hip and femoral neck with T-score less than -2.5 or by fragility fracture, fall from standing height, and minimal trauma at the hip or vertebrae. One timing screening recommended in the female greater than 5 years old. Prophylaxis measures weight bearing exercise, adequate calcium and vitamin intake throughout adult. Treatment bisphosphonate, teriparatide, SERMS, rarely calcitonin, denosumab, monoclonal antibody against rankle. Next, we have osteopetrosis, so failure of the normal bone resorption due to defective osteoclast, thick and dense bone that are prone to fracture, mutation, carving, and anhydrous to impair ability of osteoclast to regenerate acidic environment, necessary bone formation, resorption, overgrowth of the cortical fins, the marrow by pancytopenia, the hematopoiesis can result in cranial lobe impingement and pulses due to the narrowed foramina. X-ray shows diffuse symmetrical sclerosis. Okay. Bone marrow transplant is potential curative as osteoclast are derived from the monoblast. So next we have osteomalacia or rickets, that is defective mineralization of the osteoid. Osteomalacia or cartilage bone growth rickets only in children, most commonly due to vitamin D deficiency. X-ray shows osteopenia, pseudofracture in osteomalacia, facial widening, metaphyseal coughing and fraying in rickets. Child with rickets have pathological bow leg, genuvarum, bead-like postchondral junction, brackets rosary, rhinotapes, decreased vitamin D, decreased cellular calcium, increased protease segregation, and decreased phosphate. Hyperactivity of the osteoblast, increased ALP. Next, we have the osteitis deformans, also called Sprague's disease of the bone, commonly localized disorder of the bone remodeling caused by increased osteoclastic activity followed by osteoblastic activity that forms the poor quality bone. Serum calcium, phosphorus, and PTS levels are normal. Increased ALP, mosaic pattern of the woman and lamellar bone, osteocytes within the lacunae in a charcoid juxtaposition, long bone sarcastic fracture, increased blood flow from increased arteriovenous shunt may cause high output failure, increased risk of osteosarcoma. Head size can be inserted due to the skull thickening. Hearing loss is common due to skull deformity. Stage of practice is lytic osteoclast, mixed is osteoclastic osteoblastic, sclerotic is osteoblastic. Quiescent is minimal osteoclast and osteoblast activity. Treatment is bisphosphonate. Next, we have the avascular necrosis of the bone. Infarction of the bone and marrow, usually very painful. Most common site is femoral head watershed zone due to insufficiency of medial circumflex femoral artery. Cause includes of avascular necrosis with corticosteroids, chronic alcohol overuse, sickle cell anemia, trauma, SLE, veins, Casson's depression disease, legs, calf, Barthes disease, Gaucher's disease, slip capital femoral liver, the cast bends legs. So C for corticosteroid, A for alcoholism, S for sickle cell, T for trauma. So cast को भयो अब casts मा SLE छ S बाट अनि bend बाट bends, that is the casion decompression disease, and leg Barthes disease, Gaucher's disease, and slip capital femoral liver. So the next is the lab value in bone disorders. So we have the osteoporosis where all the values are normal. Osteopetrosis only decreases the normal is the calcium, rest values are normal. Package disease of bone increase only increasing the ALP. When talking about the osteitis fibrosis cystica, in package disease abnormal mosaic bone architecture, whereas osteopetrosis has dense brittle bone, calcium decrease in severe malignant disease, and osteoporosis there is decreased bone mass. Now we're talking about osteitis fibrosis cystica, that is primary hyperparathyroidism. So parathyroid is increased first, then the calcium is increased, phosphate decreased, and ALP is increased. So brown tumor due to fibrous replacement of the bone, subperiosteal thinning, idiopathic or parathyroid hyperplasia, adenoma or carcinoma. So secondary hyperparathyroidism mostly occurs in the CKD, increase in phosphate cannot throw out. So increase in the PTH, okay, and the phosphate binds with the calcium, decreasing the calcium, and there is increasing ALP. ALP is increasing also. After onwards, from Paget's disease, osteitis fibrosis cystica, osteomalacia rickets, and hypervitaminosis D, all in except in hypervitaminosis D, all these four increases the ALP. Okay, so now we'll be talking. So secondary hyperthyroidism often has compensated of secondary decreased phosphate excretion and production of activated vitamin D. Now we have osteomalacia rickets. So here there is a decrease in calcium and phosphate, there is increase in ALP and increase in PTS. Soft bone, vitamin deficiency causes secondary hyperparathyroidism. Next we have the hypervitaminosis D, that is there is the increase in calcium, increase in phosphate, but decrease in PTS caused by oversupplementation or granulomatous disease like sarcoidosis. So next we'll be talking about the primary bone tumors, that is the metastatic disease is more common than the primary bone tumor. Benign bone tumors that starts with O are more common in boys. Okay, so that is the osteochondroma, osteoid osteoma, and osteoblastoma are more common in boys. Okay, so now we'll be talking about the osteochondroma, that is the males less than 25 years, benign, metaphysis of long bone, lateral body projection of growth plate, continuation with the marrow space covered by cartilaginous cap. So rarely transform to chondrosarcoma. Next is osteoma, middle is soft face of the facial bone, as with the Gardner syndrome, osteoid osteoma, cortex of the long bone. Okay, so presents as the bone pain, watch at night, that is relieved by anesthesia, bone mass less than 2 cm with resolution to osteoid core. So we have osteoblastoma, that is in the vertebrae, that is similar histology to osteoid osteoma, but larger, greater than 2 cm, pain on to anesthesia. Okay, chondroma, we have the larger pain on responsive to NSDs. Okay, so osteoblastoma, there is always pain. Okay, so next is the chondroma, that is medulla of the small bone of the hand and feet, benign tumor of cartilage, a giant cell tumor, 20 to 40 years old, epiphysis of the long bone, often in the knee, locally aggressive benign tumor, neoplastic mononuclear cells that express frankel and reactive mononuclear giant cells like osteoclast-like cells, osteoblastoma, show bubbles in appearance of X-ray. So next we have the osteosarcoma, that is osteogenic sarcoma, account for 20% of the primary bone cancers. Peak incidence primary tumors male in less than 20, less common in elderly. The secondary to predisposing factors like Paget disease of bone infarction, radiation, familial retinoblastoma, and Lee-Fromme syndrome. Location metaphysis of long bone. So characteristic is pleomorphic osteoid producing cells like malignant osteoblast, present as a painful enlarging mass or pathological fracture. Quadrant triangle of elevation of peristome or sunburst pattern of the X-ray. Aggressive primary, usually responsive to treatment, surgery, chemotherapy, poor prognosis. Chondrosarcoma, which is medulla of the pelvis and proximal femur and humerus, tumor of the malignant chondroids. Sarcoma, most males less than 15, diaphysis of long bone, pelvis and flat bones, anaplastic small blue cells, neuroectodermal origin, resemble lymphocytes, different from conditions with the similar morphology like lymphoma, chronic osteomyelitis by the testing with 1122, that is the fusion protein for EWS FL11, onion skin peristem reaction in bone, aggressive with the ordinates but responsive to chemotherapy. 11 plus 20 equals to 33, that is me. So next we'll be talking about. So now we'll be talking about the osteoarthritis, that is mechanical wear and tear, destroyed articular cartilage, degenerative joints disease, inflammation with the inadequate repair, chondrocytes, immediate degradation, inadequate repair. Okay. So osteoarthritis, there is female obesity and joint trauma. So pain in the weight bearing joint after use. At the end of the day, improving with rest, asymmetrical joint involvement, knee cartilage loses begins medially, bow-legged, no systemic symptoms, osteophytes, bone spurs, joint nerving, subchondral sclerosis and cyst, synovial fluid, non-inflammatory WC less than 2000, development of Haybardian node at the DIP and Boucher node at PIP, first MCP joint, not MCP, activity modification, acetaminophen, NSD, and intraarticular glucocorticoid. We have rheumatic arthritis, that is autoimmune inflammation and induces formation of the pannus, proliferative granulation tissue, which erodes the articular cartilage and bone. So rheumatic arthritis, there is a female, HLA-DR4, tobacco smoking, rheumatic factor IgM antibody that targets against IgG-Fc region in 80%, anticyclin peptide antibody, more specific. Pain, swelling and morning stiffness lasts greater than 1 hour, improving use, symmetrical joint involvement, symmetrical symptoms, fever, fatigue, weight loss, extra articular manifestation. There is in rheumatic arthritis, there is erosion, articular osteopenia, soft tissue swelling, subchondral cyst, joint space narrowing, deformity, cervical subluxation, ulnar finger deviation, swan neck, botanier, involves MCP, PIP, wrist, not DIP or MCP. You need to remember rheumatic arthritis don't involve DIP or first MCP. So treatment of rheumatic arthritis includes NSAIDs, glucocorticoid, disease modifying like methotrexate, sulfasalazine, biogenetic, TNF-alpha inhibitors. So now we'll be talking about the extra articular manifestation includes the rheumatic nodule, fibrinoid necrosis with palisading histiocytes, and in some cutaneous tissues, lungs plus pneumoconiosis, that's the Kaplan syndrome, interstitial lung disease, pleuritis, pericarditis, anemia of the chronic disease, neutropenia, splenomegaly with Feldis syndrome, AA amyloidosis, Sjogren syndrome, scleritis, and carpal tunnel syndrome. So in the gout, we have the acute inflammatory monoarthritis caused by the precipitating of the monosodium urate crystal in a joint. The spectre is the male, sex, hypertension, obesity. So now we'll be talking about acute inflammatory monoarthritis caused by precipitating monosodium urate crystal in a joint. Risk factor includes male, sex, hypertension, obesity, diabetes, dyslipidemia, alcohol use. Strongest risk factor is hypercalcemia, hyperuricemia. So underproduction of uric acid, 90% of the patient, largely idiopathic, potentiated by renal failure, can be exacerbated by certain medication like thyroid diuretics. Overproduction of the uric acid, 10% of the patient, Disney-Anden syndrome, PP excess, increased cell turnover, tumor lysis syndrome, or von Grafe disease. So crystals are negative shaped or negative bifringe under polarized light, under parallel light, in blue under perpendicular light. Serum uric acid may be normal during acute attack. So gout, there is asymmetrical joint distribution, joint is swelling, red painful. Calcium is painful. MTP joint of big toe podagra, tophus formation, often on external ears, oligamental bursa are this tendon. Attack tends to occur. Large attack meals with food, rich in purines, meat, okay, seafood, trauma, surgery, dehydration, diuresis, or alcohol consumption. Alcohol metabolite potential for same excretion site in kidney as uric acid, decrease urine secretion and sequestered buildup in blood. So acute there is NSDs, indomethacin, glucocorticoid, colchicine. Colchicine prevents xanthine oxidase inhibitor, allopurinol and fluvoxetine. Calcium pyrophosphate deposition disease, like previous called the pseudogout, deposition of the calcium pyrophosphate crystal within joint space, occurs in patient greater than 50 years old. Both sexes affected equally. Usually idiopathic, sometimes associated with the hemochromatosis, hyperparathyroidism, joint trauma, pain and swelling with acute inflammation, pseudogout, or chronic degeneration called pseudoarthritis. Most commonly affect joints in the knee, chondrocalcinosis, cartilage calcification on X-ray. Crystals are rhomboid and V plus, bifinger under full light, blue when parallel to light, acute treatment, anesthesia, colchicine and glucocorticoid and colchicine. So the blue when parallel positive bifingement, calcium pyrophosphate and pseudogout. So next is the systemic juvenile idiopathic arthritis. That is the systemic arthritis seen in less than 16 years old, usually present with the daily spike fever, salmon pink macular rash, arthritis, commonly 2 plus joint, is with the enterouveitis, frequently presents with the leukocytosis, thrombocytosis, anemia, increased HR and increased CRP. Treatment anesthesia, steroid, methotrexate and TNF alpha inhibitors. In Sjogren's syndrome, we have autoimmune disorders characterized by the destruction of the exocrine gland, especially lacrimal, salivary, by lymphocytic infiltrate, predominantly affects the female 40 to 60 years old. So findings is inflammatory, joint pain, keratoconjunctivitis sicca, decreased hair production and subsequent corneal damage, xerostomia, decreased salivary production, mucosal atrophy, firing of the tongue, presence of antinuclear antibody, rheumatic arthritis factor can be present in the absence of rheumatic arthritis, anti-ribonuclear protein antibody SSA, anti-Ro and anti-LA, that is SSB, bilateral carotid enlargement, anti-SSA and anti-SSB may be present in SLE. A common primary disorder or secondary syndrome as with the other autoimmune disorders like rheumatic arthritis, SLE, systemic sclerosis. Complication includes dental caries, mucosal lymphoid, mild lymphoma may present as a parotid enlargement, increased risk of giving birth to baby with neonatal lupus, focal lymphocytic ciliatinitis on labia, salivary gland biopsy can confirm diagnosis. So septic arthritis, Asorius, Streptococcus, Neisseria gonorrhoeae are common cause. Affect joint is swollen, red, painful, spinal joint, WC greater than 50,000. Disseminated infection, STDs can present as either purulent arthritis, knee or triad of polyarthralgia, tenosynovitis and dermatitis. Seronegative spondylitis, arthritis without rheumatic factor, no anti-IgG antibody, strong estrogen with HLA-B27, MSC class 1 serotype, subtavis pair, share variable occurrence of inflammatory back pain, as with the morning stiffness, improve with exercise, peripheral arthritis, ethitis, that is inflamed insertion site of tendon and arteries, you have dactylitis, that is sausage finger, uveitis, so psoriatic arthritis as with the skin psoriasis and nail lesion, asymmetry and patch involvement, dactylitis, and pencil income deformity in DIP. On X-ray, seen in fewer than 1/3 of the patient with psoriasis. We have ankylosing spondylitis, that is symmetrical involvement of the spine and sacroiliac joint, ankylosing joint fusion. Now we have uveitis and aortic regurgitation. Bamboo spine, or costovertebral and costotendon ankylosis may cause restrictive lung disease. Monitor degree of reduction, chest wall expansion to assess the disease severity. Inflammatory bowel disease, we have the Crohn's disease, ulcerative colitis are often associated with the spondyloarthritis. So reactive arthritis is conjunctivitis, uveitis and arthritis. You can't see, can't pee, can't bend my knee. So associated with the Shigella, Campylobacter, E. coli, Salmonella, Chlamydia and Yersinia. So the next is the SLE, that is systemic limiting and relapsing autoimmune disorder. Organ commonly primary due to the third hypersensitivity reaction and lesser degree to type 3 hypersensitivity reaction, as with the deficiency of all the complementary proteins C1, Q, C4 and C2. Decreased clearance of immune complex, classically present with the rash, joint pain, fever of reproductive age, increased prevalence in Black, Caribbean, Asian and Hispanic population. Limb and sac endocarditis, non-bacterial varicose thrombi is usually or mitral or aortic valve, can present on either surface of the ball. LSLE in SLE. Lupus nephritis is glomerular deposition of the DNA anti-DNA immune complex, can be nephritic or nephrotic, cause hematuria or proteinuria. Most common severe type is diffuse proliferative. Common cause in death in SLE is infection, cardiovascular disease like accelerated CAD, kidney disease, and immune complex skin. So in an anti-SSA pregnant patient, increased risk of newborn developing neonatal lupus, congenital heart block, periorbital diffuse rash, transaminitis, and cytopenia at birth. So rashes on pain is the mnemonic. Rash or pain. So R for rash, that is malar or discoid. A for arthritis, that is non-erosive. S for serositis, pleuritis, or pericarditis. H is hematological disorders like cytopenias or rash finished. Now or is oronasopharyngeal ulcer, usually painless, and R for renal disease. Now we have rash or pain. So pain is P for photosensitivity, A for anti-nuclear antibody, I for immunological disorders like anti-DS, DNA, and anti-Smith, antiphospholipid, and N is neurological disease like seizures and psychosis. So next we have the mixed connective tissue disease, the features of SLE, systemic sclerosis, and polymyositis associated with the anti-U RNA antibody. So antiphospholipid syndrome is primary or secondary autoimmune disorders, most commonly in SLE. Diagnosis based on the clinical criteria including the history of thrombosis, artery or venous or spontaneous abortion, along with laboratory finding of lupus anticoagulant, anticardiolipin, anti-beta-2 glycoprotein 1 antibody, treatment with systemic anticoagulation. So in antiphospholipid syndrome we have anticardiolipin antibody called false positive PDRL or PRPP. Lupus anticoagulation can cause prolonged PTT. This is not correlated by the addition of the normal platelet-free plasma. Next we have the polymyalgia rheumatica, that is pain and stiffness in the proximal muscle, shoulder, hip, often with the fever, malaise, weight loss. Does not cause muscular weakness, often common in female greater than 50 years, as to with the giant cell arthritis. So increased ESR, increased CRP, and normal CK. Rapid response to low dose corticosteroid. Next we have the fibromyalgia, more common in female 20 to 50 years. Chronic widespread musculoskeletal pain with the tender point, stiffness, paresthesia, poor sleep, fatigue, cognitive disturbance, fibro, fog, treatment regular exercise, antidepressant, neuropathic pains, gabapentin. Next we have polymyositis, dermatomyositis, that is non-specific plus Yani, increased CK, anti-ZO, that is histidine, RNA, tRNA synthase, and positive anti-SRP signal recognition particle plus positive anti-MI2 helicase. So in polymyositis, we have progressive symmetrical proximal muscle weakness characterized by the endomysial inflammation with CD8 T cells, often involves shoulder. We have the next is dermatomyositis, clinically similar to polymyositis, but involves Gordon's papule, photodistribution, facial erythema, erythropic rash, okay, and darkening and thickening of the finger toe, and sites results in the irregular, dirty appearing mark, increase risk of occult malignancy, perimysial inflammation, atrophy with CD4 plus T cells. Myositis ossificans, that is heterotrophic ossification, involves skeletal muscle, quadriceps, as with the blunt muscle trauma, presents as a severe pain of soft tissue mass. Imaging shows XL classification. Histology shows the metaplastic bone tumors, area of fibroblastic proliferation, benign but may be mistaken for sarcoma. Next is we have the vasculitis, that is the large vessel vasculitis, that is giant cell temporal arteritis, female greater than 50 years old, unilateral headache, possible temporal artery tearness, jaw claudication may leads to irreversible blindness or anti-ischemic optic neuropathy, as with the polymyalgia rheumatica. Most common affects the branch of carotid artery, giant cell arteritis, the focal granuloma inflammation, increase ESR, treatment with high corticosteroid prior to temporal artery biopsy or prevent blindness. So the next is Takasaku arthritis, usually Asian female less than 40 years old, pulseless. So next we have the Takayasu arthritis, usually Asian female less than 40 years old, pulseless disease, weak upper extremity, pulse, fever, night sweats, arthritis, myalgia, skin nodule and ocular disturbance. So the granulomatous thickening and narrowing of the aortic arch and proximal greater vessel, increase ESR and corticosteroid. So median vessel you have BKP. So Burgess disease, thrombosis, obliterans. So next we have the Burgess disease, thrombolysis entrance, heavy topic smoking, less than 50 years male, intermittent claudication may be secondary to gangrene, autoimputation of a disease, superficial nodular fibrosis, red and fever is often present. So there is segmental throbbing vasculitis and vein and knob impingement. Treatment different is tobacco, smoking, cessation. Kawasaki disease is mucocutaneous lymph node syndrome, usually Asian children less than 4 years. There is crash pneumonic with the Kawasaki disease, there is conjunctival injection rash. So we'll be talking about the Kawasaki disease, that is having conjunctivitis, injection, rash, that is polymorphic disc chromatin, adenopathy, cervical greater than 1.5, strawberry tongue, oral mucositis, and hand-foot disease. Okay, fever, high-grade fever greater than 5 days. So the may develops coronary artery aneurysm, thrombosis or ruptured may cause death. Treatment is IV immunoglobulin and aspirin. Next we have polyarthritis nodosa, usually middle-aged male, hepatitis B serotype in 30% patient, fever, weight loss, malaise, headache, abdominal pain and melena, hypertension, neurological dysfunction, cutaneous eruption and renal damage. So it typically involves the renal and visceral vessels, not pulmonary artery. Different stages of transmural inflammation with fibroid necrosis, innumerable renal microaneurysm and spasm on arteriogram, string of pill appearance. Treatment is corticosteroid and cyclophosphamide. Small vessel vasculitis is Behcet syndrome, increased incidence in people of Turkish and Eastern Mediterranean descent. Recurrent aphthous ulcer, genital ulcer, uveitis, erythema nodosum can be preceded by HSB or parvovirus. Flare lasts 1 to 4 weeks. Immune complex vasculitis as with the HLA B51. Cutaneous small vessel vasculitis occurs 7 to 10 days after a certain medication. Penicillin, cephalosporin, phenytoin, allopurinol. Infection like HSB or HIV. Palpebral purpura or no visceral involvement. Immune complex mediated leucoclastic vasculitis, late involvement in systemic vasculitis. Next step includes small vessel vasculitis, which includes eosinophilic granulomatous with polyangiitis, granulomatous with polyangiitis, immunoglobulin, that is A vasculitis, microscopic polyangiitis, and mixed cryoglobulinemia. So the eosinophilic granulomatous with polyangiitis includes asthma, sinusitis, skin nodules or purpura, peripheral neuropathy, wrist drop and foot drop. Can be involved with the heart, GI, kidney, and autoimmune glomerulonephritis, formerly known as Stokes-Strauss disease. Granulomatous aggravating vasculitis with eosinophilia, MPO, NCA, PNCA, increased Ig level. So granulomatous with polyangiitis is upper respiratory and lower respiratory tract. Okay, so that was eosinophilic, that is Stokes-Strauss, whereas granulomatous with polyangiitis is upper respiratory tract perforation of nasal septum. We have the chronic sinusitis, otitis media, and mastocytitis. Lower tract infection like hematasis, cough, dyspnea, and renal. We have renal cell cast. We have the triad of focal necrotizing vasculitis, necrotizing glomeruli in the lungs and upper airway, necrotizing glomerulonephritis, PR3 NCA or CNCA or antiprotease 3 positive. We have large nodal deposit. Treatment corticosteroid in combination with rituximab or cyclophosphamide. We have immunoglobulin A vasculitis. Most common childhood systemic vasculitis are often due to URI. Classical triad of hemorrhage, school and purpura, hinge pain, arthalgia, stomach pain, abdominal pain as with the interception, palpebral purpura or buttock pain. So formerly known as hemorrhage, school and purpura, vasculitis secondary to IgA immune complex deposit as with the IgA nephropathy and Burgess disease. Supportive care and possible corticosteroid. Next we have the microscopic polyangiitis. Necrotizing vasculitis commonly involve the lungs, kidney, and skin with autoimmune glomerulonephritis and palpebral purpura. Presentation similar to granulomatosis with polyangiitis but without nasopharyngeal involvement. No granuloma, MPO, NCA, PNCA, antipyretic peroxidase, cyclophosphamide, and corticosteroid. Next we have the mixed ligaments, often due to the viral infection like SCV, triad of palpebral fever, weakness, and arthritis. May have the peripheral neuropathy and renal disease like glomerulonephritis, cryoglobulinemia, and immunoglobulin that precipitated in the cold. Vasculitis due to mixed IgG and IgM immune complex depression. Next we have the myasthenia gravis, most commonly an MZ disorder, autoimmune to postsynaptic ACTH receptor. There is fatigability, muscle weakness, ptosis, diplopia, proximal muscle weakness, involvement, dyspnea, bulbar muscle involvement, dysphagia, difficult chewing, spread reflex, portion with muscle use, as with the thymoma and thymic hyperplasia. Reversible symptoms, pyridostigmine for treatment, nambotitan, uncommon, autonomic to presynaptic calcium channel, decreased ACTH release, proximal muscle weakness, autonomic symptoms like dry mouth, constipation, impotence. There is hypodiflexia, improved with muscle use, small cell carcinoma, and minimal effect. Now we have the Raynaud phenomenon, decreased blood flow to skin due to arterial small vessel vasospasm in response to cold or stress. Color change from white ischemia to blue hypoxia to red deperfusion, most often in fingers and toes, also called Raynaud disease, primary idiopathic, and Raynaud syndrome when secondary to disease process such as mixed connective tissue disorder, SLE or CREST syndrome, limited form of systemic sclerosis, data ulceration like critical ischemia seen in the secondary Raynaud phenomenon with the treat with calcium channel blockers. So next we have the scleroderma, that is the systemic sclerosis, triad of autoimmunity, non-sclerotic vasculitis. We have next is the Raynaud phenomenon. So it decreases blood flow to the skin due to arterial small vessel vasospasm in response to cold stress. Okay, and color change from white ischemia to blue hypoxia or red reperfusion. Most common occurs with the finger and toes, also called the Raynaud's disease. And Raynaud syndrome is when secondary to a disease process such as mixed connective tissue disorder, SLE or CREST syndrome, limited form of systemic sclerosis, diffuse ulceration, critical ischemia seen in the secondary Raynaud syndrome, treated with calcium channel blockers. So systemic sclerosis, triad of the autoimmunity, non-inflammatory vasculopathy, and collagen deposition with fibrosis. Commonly sclerosis of the skin manifesting as puffy topped skin without wrinkles, fingertip pitting, can involve with other systemic renal scleroderma, renal crisis treated with ACE inhibitors, pulmonary intestinal fibrosis and pulmonary hypertension, esophageal dysmotility and reflux, cardiovascular defects. So diffuse scleroderma is widespread skin involvement, rapid, progressive, oddly visceral involvement with the anti-scler SCL70 antibody and DNA topoisomerase 1 antibody and anti-DNA, anti-RNA polymerase 3. So limited scleroderma, limited skin involvement confined to fingers and face, although with CREST syndrome, calcaneous cutis and anti-centromere antibody, Raynaud phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia.